I do want to ask you, how do you think these new criteria can be played out in the real world, in private practice, in clinical trials? What is really the hope here, do you see, with these new criteria?
Well, the hope is they'll be used. And the reason why I think they could be used is they're first simple and practical. BSA is easily performed, well established. In fact, BSA is probably used by most dermatologists who treat a lot of psoriasis. And in some electronic health records, BSA is a pull down. It's built into the psoriasis visit template. So no problem there. We know how to do that. The classification probably would overcome misclassification. The reason why doctors often don't use these drugs or modalities appropriately is they feel locked in by the 10% BSA rule. This allows an escape hatch, so to speak, from the 10% rule. And I think if you really look at how we treat people with psoriasis, we often go below 10%. We need cover. We need something that allows us in a real world setting that makes sense from a patient care perspective, allows us to drop below 10% when we really need to. I always joke, none of us wants to use expensive, hard to get approved drugs unless we really think the patient needs it. And sometimes they're 5 to 7% BSA. So this allows that. This also is scientific. It overcomes misclassification. You know, there are many people with BSAs of 7% who have a DLQI as high as people with 15%. We talked about that earlier. It's not a strict correlation. There is a correlation in BSA to DLQI, but there are many patients, especially with special areas involved, the DLQI is really high and they're really burdened. So that makes it patient-centered. Patients are getting the therapy they need based on the severity of their condition and how it affects them and where it affects them. And most importantly, it doesn't forget about the special areas and past topical treatment failures. It gets doctors away from topical churn, continuously throwing different types of topicals, different strengths, different potencies, different MOAs without success. It gives them the exit ramp from topical therapy immediately, without regard again to BSA. All of this I would summarize in the following way. It's patient-centered, because I think if patients are surveyed, and I know this for the fact, there's a lot of dissatisfaction with how they're treated, psoriasis patients. And probably that comes down to, we just don't do enough. And Andy, you and I know we have at our disposal amazing tools, amazing medications that do a lot, that over half the time clear people. At 70% of the time, they get them 90% better. And new medicines coming down the pike that are just as good, if not better, some of which are oral. We need exit ramps from these old constraining classification systems, allow us to do what's best for patients. And my happiest patients are often those who would never get into clinical trials, yet are made better by the tools at our disposal.
Yep. I want to emphasize one more thing, and that's a word you used earlier to describe topical therapies in patients who might not meet the current criteria, and that's inhumane. That's a great word to use when dermatologists, I think, are stuck with the older rules and this BSA 10% rule, and you have a patient sitting in front of you with horrible scalp psoriasis or horrible shin psoriasis or horrible genital psoriasis, and you're telling them they can't use one of the newer, great, terrific drugs in psoriasis. To me, that is inhumane. And so, to say it's patient-centered, I would also say that it's humane. This new criteria that we're proposing here really is about doing the best thing for this person that's sitting in front of you. Okay, Bruce, let's talk a little bit more about applicability of the new criteria. So all of us know dermatology practitioners who are reticent to prescribe biologics. Can you give us some advice for those individuals and perhaps how these new criteria can help them?
You know, the first thing I would say is biologic prescriptions are easy because the drugs are easy to use. They don't require monitoring, and they work well. Uh, the hardest part, of course, is getting a prior authorization and approval, but you get a system in your office down, and then you open up a whole world regarding the use of medicines that work and make people very happy and don't require a lot of work on your part. For example, most of these drugs work so well that follow-up visits can be really pushed out many, many months, if not a year, in people on long-term safe therapy. And our practice has actually moved to teledermatology for these specific types of visits. So you're looking at a very easy, quick visit. Patients are happy. Can be done over telederm. It can be done in person. They're almost the easiest visits of the day. Now, a more temperament approach that I would give a practitioner is you want to make people better. And if you want to make people better, which is why we all went into dermatology, why wouldn't you use therapies that work much greater percentage of the time than older therapies or topicals, and are safe again? Many of us have actually discussed how these patients who are suffering with, say, 5 to 10% BSA, but of course much larger amounts of body surface area involvement, are deserving of effective therapies and are thankful. So the gratification that you feel taking care of patients who truly are in need and making them better, and then making your office work better because the monitoring is easy, the visit frequency is easy. It's almost a no-brainer to me to use these therapies and enhance my whole attitude towards practicing dermatology.
I wanted to add on that. That's a terrific answer. I agree with everything you said. When I talk to dermatologists around the country, some of the things I hear that are what I call almost incorrect thinking or on this issue are, oh, well, biologics biologics associate with cancer or infections, and they kind of tend to lump them together. And to me, that's thinking of the newer biologics that are much more targeted to psoriasis in the same boat as the older biologics, for example, TNF blockers, where we did see some issues with those drugs. And I think the fears that were established early on with the early classes of biologics are pretty unfounded now with our newer classes of biologics. So I really encourage everyone not to kind of lump biologics together, but really think of the newer ones as not only being much more effective, but much more safe as well. Okay, Bruce, can you go over some of the limitations of the Delphi process and the new criteria that we developed?
Well, every effort has limitations. For one, as I spoke to earlier, the final definition that won the day excluded patient-reported metrics. And that wasn't lost on us. But we also had results that were limited by those who chose to participate. Remember, this was a group of experts. We didn't have community dermatologists. We didn't have patients with psoriasis. And of course, those people matter. And if this exercise were ever to be repeated, we'd probably want to include some community dermatologists and patients to help guide us a bit better. All that being said, the whole goal of the effort was to make this accessible to community dermatologists, easy to use, and really geared towards patients. It was a patient-centered effort.
I might add also, it was an international effort, right? So the International Psoriasis Council has counselors from all over the world. And so I agree with the limitations you stated, but one of the positives was that we involved folks practicing psoriasis dermatology across the world.
Right, and it was many countries. And so I also agree with you. The fact that it was so international made us arrive at almost a universal definition, not one that's constrained by local rules and payers.
Right.
So Andy, I think it's easy to integrate this definition into clinical practice, but as you know, being a very active clinical trialist in psoriasis, more will get behind the effort if companies and the FDA, for example, agree that the definition holds water and should be used for entry criteria and or assessments during the course of clinical trials. How do we get to that end?
Well, I want to first talk about the FDA a little bit. So they're the ones that have driven entry criteria for many years. And so you and I and others have spoken many times to companies who are developing pipeline drugs for psoriasis and telling them about these patient populations that really should be entered into their trials. We need to study them. We need data on them. But the barrier often is the FDA. So I think that we would probably need a concerted effort actually to get over that barrier. Perhaps a panel of experts really to discuss this issue of broadening our definition of candidates for systemic therapy beyond BSA of 10%, which, as we have discussed many times now, seems rather limited and excludes patients really who should be tested in trials. So I think it's a matter of making a concerted effort, perhaps through the International Psoriasis Council, the National Psoriasis Foundation, perhaps other organizations, to address this with the FDA, because it certainly is true that those patients are needy and would need this type of therapy. I think historically, maybe the FDA has thought, well, systemic therapy is dramatic, it's big, we want to reserve it only for the most severe patients, so let's make the criteria this way so we don't use a systemic, perhaps toxic therapy for a more mild patient. But I think we've gone beyond that now. We know psoriasis is a serious disease. We know that, as you mentioned earlier, patients with less BSA than 10% can have a significant impact in quality of life. They can have psoriatic arthritis. They can have systemic inflammation. So I really think this is an artificial thing, and I think it would be terrific for trials. Think about it. If we had this incorporated into trials, we would be able to do subset analyses, right? We could look at the whole population. We could look at the people just with 10% BSA. We could look at the people with special areas, how they responded. So I don't think it would be that hard to incorporate these other types of patients into trials. We would simply do subset analyses and look at their impact on the whole population. It's a matter really of I think, trying to convince the FDA that these patients are worthy. And I think it's upon us, the dermatology community, to take that message to them.
I think the path is already being blazed to some extent, Andy, because we know certain companies are already attempting to get systemic therapies approved for quote unquote moderate to severe psoriasis for mild to moderate populations. And we're going to see that happen over the next year, I think. As well, other companies are testing their biologics in lower body surface area patients. We have studies on palmoplantar, we have studies on scalp, on genital. So the foundation is there. And I think we now, as you say, need a concerted effort to go to the next level. And I think this severity definition allows us a better entry model, inclusion criterion, for example, that gets these patients in. And then the final issue is, how do you measure patients who have lower objective disease burden? How do you measure them in time while they're getting clinical trials interventions? And that's a discussion for another day. And both of you and I know of some metrics that are going to work in that setting.
Right. And in particular, if we look at trials for psoriatic arthritis, where the body surface area can be quite low, can be 2%, 3%. And then when we see the PASI applied to patients in psoriatic arthritis trials, it tends to break down. It's not particularly the best measurement to use on patients with limited BSA. So I agree with you. We have to be more creative in our thinking and assessing responses in patients with lower body surface area.
So Andy, now we have this definition we've arrived at, which seems to serve really well less severe patients. By that I mean under 10% or special areas. But how will it affect the patients who do not receive systemic therapy, even though they are eligible to receive systemic therapy? And maybe give an example of a patient.
Yeah, I think this is a really important topic that we haven't touched on yet, because the term we use for this type of population is under treatment. So this is the term that we use for patients who are already eligible for a systemic therapy like a biologic, and yet they're continuing to be treated with topicals. And I liked your term earlier. You talked about the topical churn going over and over again with topicals in the mild patient, or quote unquote mild patient, how frustrating that can be. But we do have data on this topic from the National Psoriasis Foundation, where they've surveyed their constituents and have shown that there are patients with bona fide moderate to severe psoriasis who are only being treated with topical therapies as we speak. So, so we do have to address that as well. Not only are we talking about making more patients eligible for systemic therapies, but we have to treat the patients that are already eligible appropriately. And I really consider it inappropriate treatment for those patients with more severe disease that are continually being treated with topicals. And unfortunately, survey after survey of the National Psoriasis Foundation has shown that we're doing poorly in this area. As dermatologists, we still are treating way too many patients with bona fide severe psoriasis with topicals.
So what we've learned today is, through a process called a Delphi exercise, we've arrived at a novel classification system for people with psoriasis that spans all severities. It basically brackets off patients into two groups, either those who are appropriate for topical therapy or those who are appropriate for systemic therapy, and basically defines the systemic therapy group in ways that are practical for the community dermatologist or the academic dermatologist and the clinical trialist. And most importantly, it allows classification that best serves patients who truly are in need for more than just topical therapies, even though they aren't severe enough, quote unquote, to get into a clinical trial. Through these efforts, we're hoping to change the way providers approach patients with psoriasis, such that they bring to bear our modern tools that make people more satisfied when they need to be made satisfied. Andy, do you have any final comments before we shut down the program?
Well, first of all, I want to thank you, Bruce, for your support in this project, your leadership in the project. I've obviously enjoyed it immensely. I'm happy that the counselors were able to choose my statement as the ultimate statement, but I appreciated all the input, the whole process and the whole thing. I think because of that, I think it's vigorous, I think it's accurate, I think it's appropriate, and I really hope that it will be utilized both in clinical practice and in clinical trials. So thank you very much.
Thank you, Andy. And I also want to thank the audience for listening today. I hope you got a lot out of it, and I hope it changes the way you approach patients with psoriasis moving forward.